Well, there can be no conference on transforming healthcare with IT without hospital information systems. To show us the importance of this, we have two speakers. I now call upon Mr. Binod Samal, the Chief Technology Officer, Apollo Hospitals, and Dr. Karanveer Singh, the Head of Medical Informatics Department, Sri Gangaram Hospital. Ladies and gentlemen, please welcome them with a huge round of applause.
Good evening. We are behind schedule, so I'll just quickly introduce Dr. Sumant C. Raman, who is going to speak on decision support systems. Now, hospital information systems are graded by Gartner into 5, and the grading, most important when you go to 3, 4, 5, 5 is the highest, is decided by the decision support capabilities. And the topmost level is called the mentor system, where actually they will mentor the doctor and will say, do this, do that. It's like having senior person with you. And these capabilities of decision support system can define what's an international level HIS, hospital information system, from a not so level, international level. So the most important part, of course, decision support system is going to be covered by Dr. Sumant C. Raman. So would you like to start?
Presentation shows. Label mic comfortable, clear.
I want to
Then open my presentation. Yeah, shows.
sorry.
Can you call this mic? Yeah, you open my presentation. Yeah. Go to the first slide. Yeah. Good afternoon to you all. Over the next few minutes, I'm going to take you through an overview of potentially what could be one of the most relevant and important applications in the healthcare IT space over the next decade or so. We are talking about clinical decision support systems, about which we've heard a lot over the last several years, and we've done very little to actually use these systems as core part of our healthcare delivery process. So I'm going to start off with a simple question to all of us. The quality of healthcare that we receive simply depends upon who we go to, when we go to them, where we meet them, and how much time we get with them. I want all of us to sort of think for a minute on this. Is this true or is it not true? The quality of healthcare that you and I receive depends on all these things. The question is, should it depend on any of these things? Humans forget. We tend to overlook things when we are in a hurry. We have variable levels of performance depending upon our work stress, our mood. In a country like India, there is a level of training which is very variable. Many doctors simply have not had time to get retrained on the latest concepts. Fundamentally, what is the point that we are making is that the quality of care that we receive depends on a number of factors on which it should not depend. Simply put, should the quality of care that we receive be just a matter of chance or luck? I think this is a very fundamental question that we need to ask ourselves. I worked for about 7 years in critical care as a critical care physician, and when I started in the first year, there was virtually nothing that I did not know. I was the cat's whiskers. I knew everything about critical care. And then as I continued working in critical care, with every passing year, it became apparent to me that there was more and more and more stuff that was being missed, that was being overlooked, that was being forgotten, that we just did not know. And we have this opportunity to use technology today that is inexpensive, that is easily deployable to transform the quality of care that we actually deliver. So when I actually left critical care to move out into internal medicine, I realized that today in critical care units, a lot of things which happen do happen to get overlooked, errors happen, and it's not that these are done deliberately. These are just things which happen due to stress, due to people forgetting things and so on. So is there a way that we can try and change that? Now, this we all agree, I'm sure all of us in this group agree that we have to reduce this variability because we want to improve the quality of care. That's why we are all here. So how do we do it? Can we use technology? One possible option. Of course, there are other methods. You can train people better. You can ensure that there is a continuous upgradation of their skill sets and so on. But can we look here at using technology? And when we talk of technology, we're predominantly talking of using what we call as clinical decision support systems. When most of us have come here from different parts of the country or abroad, we've probably flown in here. How would you like to be in an aircraft that is completely devoid of computerized systems, completely manually run, right? So if the pilot is descending too quickly, the system will not tell him anything. I mean, he should figure out for himself he is descending too quickly. As he is touching down, the system won't tell him if his nose has to go up. No alerts on anything. If he is running low on fuel, he doesn't know about it. He's just got to figure out for himself by looking at the gauge. We don't want to travel in such an aircraft, do we? Yet, this is exactly the kind of quality of healthcare delivery that we, all of us, from the highest to the lowest in this country, seem to accept without much of a murmur. So clinical decision support systems, coming to this, what they actually are. So can software programs diagnose and provide decisions on treatment accurately? Can the use of such systems reduce medical errors? Can the complexities, one thing that we hear repeatedly, oh, it's not so simple, you can't just write a simple software program and do this. Medical science is a very, very complex problem, and it's not that simple. And can the intelligence in such systems be effectively channelized to actually manage patients? I think these are very, very important questions. The answer to most of these questions is actually yes. Much of this has been done from a technology perspective. There are challenges. There is still a long way to go in terms of getting it to where we actually want it to be, but a lot of this has actually happened already. So just look, I can draw your attention to this side. So essentially, we are putting intelligence, we are putting thinking into applications that will guide users towards making informed decisions in the process of diagnosis, investigation, and treatment of patients. Systems to provide alerts or reminders to deliver care. All of these comes under the ambit of what we call as clinical decision support systems. One of the greatest challenges in clinical decision support systems is, of course, the knowledge base. How do I have relevant data? How do I have current data in the system? Should I build clinical decision support systems that will solve all the problems of the entire universe? Or should I look at specific problems for addressing those needs? Should I use these systems for screening? Should I use them for diagnosis? Should I use them for treatment? And I think I want to draw on our experience in this space. Some of the best and most successful clinical decision support systems globally are those that are used for specific indications. Please do not think clinical decision support systems means system will diagnose and give treatment. No. We are looking at specific conditions, and I'll be sharing a few examples a little later on what kind of conditions CDSS systems can very optimally be used for. Right now, this is the current scenario. One of the major issues, doctors are reluctant in using such systems. How can a computer treat my patient? One of the conferences where I presented, a very senior pediatric surgeon actually stood up and said, yeah, so your computer will do the surgery after it gives the diagnosis. So one of the things is that there is a great deal of skepticism. There is a great deal of reluctance in using such systems. And there's also a slight feeling of being threatened, which all of us as doctors feel when these systems actually come in. They use it as a reference tool, optional. If you want, you look at it. If you don't want, don't look at it. And of course, the lack of mature EMR systems means that the doctors actually don't do anything electronic with reference to their patients, so they don't have opportunity to interact with the CDSS systems. Lack of legislation, the government really doesn't say anything about this, though the government could potentially be the biggest beneficiary, and this has been discussed earlier in this morning session as well, when there could be a tremendous increase in productivity if we deployed these systems properly. And lack of patient awareness. The patients don't know anything in our place. They don't demand the use of such systems, and therefore these systems don't get used as much as we want them to be used. CDSS systems, don't forget, they are not in a hurry. They don't have off days. They can easily be kept updated. They can be easily deployed, including on mobile devices. And I think this is very, very important. If we are talking of clinical decision support systems today, we are looking at deploying them on access devices which are available to the majority of the community. If it needs to be in the native languages, it needs to be in the native language. Those are issues of delivery. I think the first step really is conceptually to accept that these systems can improve the quality of care that we deliver. The other important highlight that I want to draw your attention to is the cost. If CDSS systems are not in widespread use today, it is not because of the cost. These things cost next to nothing. Next to nothing, and I repeat that word, the cost is negligible. It is not even significant for us to discuss in this session, and can dramatically improve the quality of care delivered, as has been seen by hundreds of studies done in different parts of the world. So what are the areas of need for decision support systems? DSSs are needed to ensure, one, we can deliver standardized care. Irrespective of whether A is there or B is there, a certain process is followed, and based on that process, the care is delivered. So we can deliver a certain level or standard level of care. B, obviously the examples that we've been hearing predominantly which deal with the elimination or reduction of medical errors. Use as screening tools in primary care. This is again a very, very important application. Mostly for governments, this can be a huge, huge plus. If the governments chose to introduce a pre-screening at primary health centers done by trained paramedical staff using expert decision support systems, it can have a huge impact on the quality of healthcare that is delivered. And finally, as a staging or grading application. Yeah, I've got a couple of minutes, so I'm going to run through a little faster. Staging of specific diseases. One of the best examples is staging and grading of breast cancers. One of our clients actually uses it in this model. They do nothing with the DSS except identify which stage and which grade the carcinoma breast is, and therefore what should be the optimum treatment for this particular condition. So I'm going to quickly run through some sample case studies of CDSS deployment. There are different models based on different stakeholders. I know that 10-12 minutes is too short a time for us to cover this vast topic. So the primary stakeholders could be hospitals, doctors, paramedical staff. Obviously, the government is a huge stakeholder, nurses, pharmaceutical companies, which we find very interesting. I'll talk about that in a minute, medical device manufacturers, insurance companies, and so on. So I'm going to quickly run you through. Essentially, you start off with the entire patient workflow. So the CDSS does pretty much what you do. You start from symptoms, history, examination, provisional diagnosis, investigations, investigation reports, final diagnosis, treatment, follow-up. So it's exactly the same pattern that you use. And like I said, various stakeholders, whether it's providers, doctors, the pharma companies, the healthcare payers, and so on. So this is a simple example of what we did in an Indian state. It's basically in Rajasthan, again through a third-party agency, which is a very large pharma company. 33,000, if I remember right, patients have, as of last month, been screened using clinical decision support systems to deliver primary care. There is a call center which is based out of Bombay, which oversees this whole process, but pretty much the village workers use the application, deployed on a mobile phone, and actually are able to deliver primary care. And we'd like to see such models scaled up. This particular model is now currently active in 120 villages. It's being scaled up to 400 villages by the month of August. The next example is basically to handle specific disease states. Example for diabetes, where you can build a model which wonderfully gives you which patients need to be treated with what kind of anti-diabetic medication, what are the follow-up protocols which need to be followed, and so on, all of which is extremely easy to build and deploy. The third I draw your attention is you can do a specialty-wise thing. If you don't want to do a disease-wise thing, you don't want to do a primary care-wise thing, you can do a specialty-wise ophthalmology. In fact, we have built with Shankar Nethralaya about 300 primary ophthalmology conditions decision support system, and this will be out into the community very, very shortly. So you can do it disease-wise and so on. The next model is basically clinical pathways-wise. So you can actually build clinical pathways using decision support systems and have those pathways validated. Example, one of our clients actually uses this to identify which patients with congestive cardiac failure need implantable defibrillators. Nothing else. Very, very specific objective. And in these kind of situations, the system is almost 100% on the job. The next very interesting application is basically this, and this is something which the government of India is looking to do now. Antibiotic policies, antibiotic sensitivity patterns across different hospitals. So all that different hospitals need to do is to input their culture sensitivity reports from their various patients. The system actually guides as to which is the most appropriate antibiotic for specific patient scenarios, and based on that it can also keep a track of what should be the appropriate antibiotic prescription patterns, and also the epidemiological surveillance system is also put in place. So this is something that we're working with the government on. The last couple of slides, the mobile application, this is just to tell you that most of whatever you saw here can be deployed successfully on mobile phones. There are challenges in terms of the volume of data that can be entered, but much of these can be overcome with the increasing developments in improved user interfaces. So this is an example of an mCare application which has been successfully deployed. So last couple of slides, what do we need to do now? We need to mainstream DSS into care delivery. This is not a reference guide. If you want, you go and look at it. If you don't want, don't look at it. This needs to be just as much as a CT scan, an ultrasound, or an echocardiogram is part of your care delivery. You need to make this a part of your care delivery. Last slide. You need to integrate it with the EMR. You need to use as screening tools, especially governments for specific disease states and diagnosis in primary care, staging and grading, integrated with existing reporting systems. This is again a very, very useful tool because it then gives the reporting systems thinking capability, and obviously it can be deployed on mobile applications. Summary, use of clinical decision support systems can dramatically transform the quality of healthcare delivered. There are any number of studies, and I'll be happy to share with you offline some of these. Systems are extremely cost effective, easy to deploy, and can be deployed on a mass scale in a country like India. The challenge is not technology, it is with the decision makers who need to wake up to the phenomenal potential of clinical decision support systems. Thank you very much.
Thank you, Dr. Sumant. That was a wonderful talk. And Dr. Sumant spoke about how we increase patient safety and using clinical decision support systems. But obviously, one of the core backbones to enable CDS is hospital information systems. I now invite Mr. Partha from IBM Healthcare Vertical. He will speak about HIS implementation challenges, the past, present, and the future. Partha, over to you.
Thank you, Vinod. Good evening. Today I got an opportunity to talk about the subject which is very core to my heart. Quickly, I have around 6 slides in this complete presentations, and I'd like to save some time for some interactions, because I truly believe this is a subject which we all are impacting, and we need to have some discussions about this. So I would like to cut short my presentation as much as possible, and definitely would like to go for some interactions with your permissions. So this is the topic that I thought we'll touch upon now. It's talking about what are the challenges for HIS implementation, primarily in India as well as globally. Then we'll come back to Indian context. Then quickly glance through what are the past challenges, current challenges, and what are the future challenges that we emphasize which may come up. When we talk about the HIS implementation challenges, the first word which comes in my mind is enormous. I was yesterday when I was thinking that what to talk about on this is the word which absolutely stuck to my mind. There are too many challenges that comes to us while we are implementing HIS. Challenges are also different from hospital to hospital. For same hospital, one implementation to the other implementations, and also from location to locations. So what are the challenges that we have faced for a 200-bed hospital that may not be valid for a 500-bed hospital? Similarly, the similar challenges may not be valid for a clinic kind of setup. Also, the challenges are different from stakeholder perspective. So as a hospital, in organizations level, the kind of challenges that we face, probably a owner of a CEO of an organization, the HIS implementation challenges are completely different from the challenges that is being faced by the department level people. Even the department level people, what is being faced in clinical department vis-a-vis admin departments are also completely different. If you look at the employee perspective, the perspective of a doctors looking at HIS implementation challenges as well as the front office clerk is also completely different. This is all known to us. IT also has a couple of challenges. Primarily, IT technology has come up one of the important challenges for them. Which technology to choose? There are too many options to choose from. Integrations. It's not that only one application that we are using. HIS needs to talk to PACS. It needs to also talk to some other mobile devices. We are also talking about that everything should be web enabled and people should be able to access information sitting at their homes. So too many integrations points we are talking about. That's definitely one of the challenges coming up to IT. Scalability is definitely one. We are starting small, but idea is to grow up. How we can design our system in such a fashion that we can start small and we can go up. Data. Again, data during implementations are primarily being provided by the departments, and then when we put this data in our systems from an IT perspective, a lot of the cases we found out these are not validated data when this was provided to us. We go back to the department, even they say that okay, this what has been there in the system right now, it is not working. This is another typical challenges that IT faces during implementations. Customizations, complexity, timeline are very important. From timeline perspective, most of the time as a IT persons in the organizations, what I used to hear, I needed yesterday, not even today. So that's definitely one of the challenge. Also, we found out the challenges for HIS implementation as well as for the telemedicines are kind of similar. So in next couple of slides, we'll talk about the challenges which will be probably applicable for both HIS as well as telemedicine. In Indian context, I would like to ask a couple of questions, and definitely in the introduction time we'll have more discussions on this. Do you have HIS? In some hospital we have a billing system, so we call it HIS. In some good hospital chain, we have a full-fledged integrated system which is providing probably 90% of the hospital functionality. We also call it as HIS. So what is the definition of an HIS? In Indian context, we still have not defined what are the different modules would be there in HIS. So if somebody is making some applications calling it as HIS, what are the different components should be there before we can call it as HIS? Now again, if we have all this module available with us, do we use all this module? This is something like a nice to have feature. During the negotiation, discussions, evaluations of the vendor, we all talk about that what are the different things we need. We get all these features, but at the end, most of the time we don't use it. Also, the other questions I'd like to put forward to all of us is talking about, is HIS the only applications in the hospital? Is it not that we are trying to do too much out of this HIS? Do we need any other applications along with HIS? Is it that HIS can do everything is required in the hospital? Important, very relevant is what is implementations. In some of my discussions with some eminent hospitals, the discussion came up like you guys are mad. You are telling that this is going to take around a year time for us to implement. And at the day end, what we are getting, you should have a CD, put it in the computer, it should work. What is implementations you are talking about? You are telling that, there are 100 man-months of effort, there are 20 people from your team and another 50 from my team is going to work. You guys have not got the technology right. Please go back to your drawing board, work a right technology for us, get that CD and it should work. Now, again, we need to understand what is implementations for us. I don't know whether I should talk about it, but I got the courage to put this the slide over here is talking about doctors are not typists. The challenge for doctors getting involved in this, most of the time when I used to go to the doctor and tell them, yes sir, why don't you use the systems? The questions comes like, what do you want me to do? Do you think that I'm a typist? Question, to get an answer for that. But at the end it works. After all these things in Indian context, we have an application which works for all of us. How it works? So we have the great Indian Jugaad. But unfortunately, it does not work for longer duration. It works for some time. I'll quickly glance through a couple of the points we will discuss. Past challenges, and I was trying to see that up to what extent the past we consider. So for our discussion purpose, we thought 2005 probably is the right time to be considered as the past. And after that, we'll consider as the present till 2011, and then 2012 onwards, we'll consider what is the future we're looking at. So till 2005, I personally have experience and exposures towards working with the hospitals from 94. So whatever the things that we have seen in the past, the challenges, we didn't have products. That time we used to go and search about what is the product. The question was build versus buy. Most of the cases, finally, we used to do it like we have an IT team, have got a couple of guys, and we developed a homegrown system. And that works. And that used to work for us. We had no control of what is being developed and what is being changed. Somebody would come up, this is the internal IT team, said, I want this tab to be changed into this. We do the changes without understanding what are the other things are happening. And next day I found out the system is not working. So definitely that was one of the very important challenge. We found out the scalability and multi-locations for HIS implementations as one of the challenge. It worked in one location, it worked with a couple of people. Once we increase the number of users, we increase the number of locations from one location to multi-locations, challenge. We found it does not work. We had a process which is mostly manual, partially automated, and whatever we have automated, we also give a record register to the people to write all these things over there, whatever they are putting it in the HIS. So a lot of duplicate effort was there that we have seen. We didn't have a lot of reliability on the system. HIS was used by pockets of people in the hospital, not by everybody. User participation orientation was not that great. It was something like something has been put to them, they have to work. It is not that they were asking for it, it is somebody is putting on their head. Inhibition of technology acceptance, we have seen that in the nurses, in the doctors, not even that we have even seen in the front office guys in earlier days. There was no value addition has been, probably the hospital seniors have got from the HIS implementations, and there was no mandate. I never heard in my KRA that, you have to implement HIS this year. So working for hospital, longer durations, that was a challenge till 2005. Also the infrastructure. Hospital does not have a data center. We have a server room. Server room is generally in the basement. Which room has not been accepted by all other departments? That's the room given to IT, and IT is very, I don't know whether happily or unhappily accepting that's the room in the hospital. We all call about this is a backbone and all these things we're discussing, but at the day in the location of a server room is that in the hospital. That was the situation. I'm not telling that's the situation right now. That is the good news. So what we're doing right now? 2 minutes. Okay. So we have now a lot of products. We are selecting the product. I'll talk about the requirement. Do we all know that what we are looking for, what we need? Defining the requirement and prioritizing the scope becomes definitely the challenge. We would like to do everything together. From a timeline perspective, every time there is no time given, we have to do it now. Data quality standards are always a challenge. Training, not only for the first implementation, but for the new employees who are joining during these HIS uses, how to retrain them and train them on the new modules and the older modules. Customizations, we always customize it and finally change the product what we got from the market. A lot of experimentation is going on right now. We are trying out a lot many models. We don't know which one is the correct one. Trying to also automate the manual process. In manual process we have 1 to 5. Probably the automation process have only 1 and 5. We may not need all the 5, but we tell the vendor, this is my process, you just automate it, irrespective of whether this is required or not required. User friendliness is one of the challenge where most of the cases our users come back and told us like this is a definitely a challenging one. Quickly, I'll take just a minute to go through what are the different things we are seeing that may come up in future. And this is from the conference that we're hearing out, and we're trying to capture a couple of points over here. Problem of many, selection of the HIS, and not only the HIS, it's a solution where HIS is one of the component, not the main component maybe. So that's something we have to look at. Re-implementation, a lot of hospitals are coming up with re-implementations where they had some HIS and they have to change it because of either technology obsolescence or functionality issues. This will be another important challenges. Social media, one thing I would like to highlight, is being discussed over here quite a few times. Patient safety is one of the area. We have a decision support system and a lot of other things which is coming up, maybe as a part of HIS or otherwise, which is very important for all of us. Hospital intelligence and medical analytics, which we feel is coming up and would be one of the challenge. And the most, probably the unavoidable challenge is the standards and regulations. We just can't avoid it. We have to gear up in some way and fashions. Last point we mentioned over here is talking about how we can reach out to masses. It is not only talking about implementing in one hospital, it's talking about how we can reach the masses. Thank you very much. I think if we have time, we can have some interactions quickly. Vinod?
Yeah, we'll just have questions for 5 minutes. Forum is open. Yes, please. Mike, please.
There should be one there.
Hello, sir. So I am Dr. Nitin from Lady Harding Medical College. I am a senior resident orthopedics there. So my question is to Mr. Sumant Raman. Sir, most of our directors from administration, they are from the before computer age. They have not been very comfortable working with them their own. So how we can address the reluctance on their part to involve to CDSS systems, number one, and number two, how much this CDSS systems will cost at a medical college level to address the patient needs and the doctor's needs. Thank you.
Okay, there were two questions. The first question is regarding, what do we do with people in the pre-computer age who are pretty much directors in administration and so on. I think this is not a problem isolated for clinical decision support systems alone. The same thing extends across to EMR, HIS, and a whole lot of other things as well. So in the case of CDSS, I think it's a lot easier because the benefits can be made visible to them very, very quickly. Again, one very important point I want to put across, please don't think of clinical decision support systems as solving all the problems of all medical conditions. Please don't look at it like that. That's where a lot of us attempt to look at it that way, and that doesn't take us very far. Take focused 1 or 2 or 3 specific problems that you're having, and you'll find that DSS systems can solve them very, very effectively for your hospital. And once they see that, I'm sure the administrators, irrespective of whether they belong to the pre-computer or post-computer age, will fall in line with that. Second question, in terms of cost, the costs of clinical decision support systems are, I would say, virtually negligible. So if you look at a per patient cost or something, it will probably be in paise, not even in rupees. But even from an institution which wants to use it for a year or something, these systems pretty much, the average cost per user is something like, even of good well-developed systems is about, even in the US, is about $200 to $300 per user per year, which quite honestly is nothing compared to the benefits that you can actually derive out of it. But when you're looking at a hospital-wide kind of thing, even then today for most hospitals it's certainly not going to cost more than maybe a couple of lakhs, maybe 3 to 4 lakhs a year, assuming a hospital had about 100, 150 doctors. So those are extremely low costs for the kind of value that it can deliver.
We are running short of time. In the interest of the agenda, we can catch up with the panelist offline. Yeah, thank you so much, Dr. Sumant. Thank you so much, Partha. And obviously, we can touch 1 billion lives with a wonderful HIS and on a digitized backbone, supported by CDS. Thank you so much.
Thank you all the dignitaries present on stage. I'd like to request the chairpersons of this session to please present the panel of speakers with the mementos. Can we have the mementos? Also, may I please invite Dr. Pramod Gaur, the Vice President, United Health Insurance USA, to please come on the stage to present the mementos to our chairpersons of this session. Ladies and gentlemen, let's all welcome them with a huge round of applause. Thank you, gentlemen, for a wonderful session.